Welcome to the Medical Level 2 Q&A. As always, we appreciate you guys chiming in. As this goes, if this is your first time, we will answer any of the questions that were submitted previous. So when you guys registered, you had the ability to ask a question. If you always want to make sure we get to those questions, please submit the questions when you register for the event. We're going to go through those first. And then at any point in time, if you have questions, if we don't answer your question exactly how you wanted, just down at the bottom of the screen, there's a little Q&A button. Click on that, and you can send us a question right now, and be happy to answer it if we've got an answer. Okay?
Definitely. So let's get started.
All right, let's get going. Okay, so first question we've got here. What are the newest updates to the SFMA? Can you please review head neck mechanics for the golf swing? Lori. Okay, so well, there's two big things there. Why don't I go through the latest of the SFMA, and then we can talk about what the head and neck does in the golf swing.
Sure.
Okay, so what I'm going to do, because depending on when you took the SFMA for the first time, some of you have taken SFMA through functional movement systems, and now you've taken it here through TPI, and you can see we've made some major updates this year. If you've taken our level 2 online 2 or 3 years ago for medical, the SFMA has completely been modified and updated. We actually have been collecting suggestions for almost 3 years now, and when we decided to go expand the SFMA and make it better, we decided to take all those suggestions into play, and literally we've made some big changes. So let me quickly highlight. I'm going to share my screen here so you guys can see this. Let's go to screen share. Hopefully this will pop up on your screen. It looks like a 3D is on there. Let me get rid of 3D and let me put this up there. Hopefully you can see the latest flow charts up there. Okay. If you guys have any technical problems, just let us know. But basically, let's talk first of all about the color system in the breakouts. So SFMA, if you remember, in the top tier, if I go to the top tier, we use this traffic light. Red means you can stop because it's normal. It's functional, non-painful. Green means that you need to attack. Go, hit the gas pedal. That's dysfunctional, non-painful. Those are our priority ranking number 1. And then we had our painful patterns, the yellow lights, the caution lights, functional, painful, or dysfunctional, painful. Now in the top tier, that made sense. When we got to the breakout, all of a sudden the colors changed. We had orange and blue lights. Red didn't mean normal. It meant there was pain and there was some confusion. So the first thing we did, and if you're new to the SFMA, just forget what I'm saying. It's all been changed. But now in the breakouts, the colors match. If you see green, it's usually something that's DN and that we want to attack. If you see yellow, it's one of the caution or the painful patterns. If you see red, it's absolutely normal. And basically, we got rid of the orange and blue colors. It just has arrows that tell you to keep going versus stopping in the past. For you guys who saw this in the past. So color patterns have changed and they match. We also just label everything diagnostic-wise. You're either going to get a mobility problem or a stability problem. We used to try and differentiate mobility problems as either a tissue problem or a joint problem, which we could do sometimes. We couldn't do other times. Now we just say, hey, it's a MD, it's a mobility dysfunction, and let you do your local biomechanical testing to see where the problem is, joint or tissue. Now, from a breakout standpoint, when we go and break out each one of the patterns, you remember in the SFMA, if we find something in the top tier that was dysfunctional, like I always say, it's like you're a gold miner, right? And basically there's 7 tunnels that you got to go look at, but we have some software that scans the tunnels, and that software tells us if there's gold in that tunnel. If there's gold in the tunnel, you have to go break it out. So if you go break out that tunnel, literally we're going to hopefully find something. And in these breakouts, we've made some modifications as well. Cervical spine, really the only thing we changed was the colors. That's still the same. In the upper extremity breakout, first thing you're going to notice is in the upper extremity, we had some rules in the SFMA, or clinical pearls. One of the rules was that if you had somebody who had a thoracic spine problem and they had a shoulder problem, that were both mobility problems. In other words, they can't turn their thoracic spine or extend their thoracic spine, and their shoulder has a mobility problem. From a clinical pearl standpoint, we would always say treat the spine first. Because if you treat the shoulder first and the spine doesn't move, the shoulder could become unstable. So we're always saying, hey, let's go after spine first. So we switched the order of what we tested. Before we used to test the spine last. Now we test the spine first. We're like, let's just go ahead and test that lumbar lock. That way I know if that's dysfunctional, I'm going to be working on that first anyway. And then we check the shoulder after. So nothing's really changed except for the order. We just moved the lumbar lock up front in the upper extremity patterns for pattern 1 and pattern 2. In the flexion breakout, we had one big change here. We got rid of the single leg toe touch. No matter what happened before, you always went to long sitting. So we just start with long sitting. And basically we get down to the active straight leg raise like normal. And now, as if you remember, we have the stabilized Faber test with hip extension, because we showed that pelvic orientation can affect hip range of motion. So in other words, if your pelvis is more posterior tilted, it can actually open up your hip range of motion. That stabilized Faber showed us that, did you have a hip impingement problem or did you have a pelvic orientation problem? Well, a lot of people were asking us, why are you checking to see if there's a pelvic orientation problem just on hip extension? Can it also affect hip flexion and rotation? And the answer is yes, it can. So we actually added a stabilized active straight leg raise test. So now if somebody fails the active straight leg raise, we do a stabilization procedure where you see that on the videos, is basically we have them get in the hook line position with their knees bent. We have them do some type of core stabilization, bracing their pelvis, then extend the legs, and then go ahead and try and do an active straight leg raise. If all of a sudden now it's better, well, you don't have a hip flexion problem, you have a pelvic orientation problem. So we added that stabilized active straight leg raise to hip flexion. You also see that when we get the rotation, we added one there as well. Everything else is still the same. I'm going through this quick because I'm assuming this question is for people who've seen the old SFMA versus the new one. You can always ask questions if you have any. Multi-segmental extension, this was a big one. If you remember, we used to have 3 breakouts. We had the spine, we had the upper extremity, and we had the lower extremity. We combined the spine and the upper extremity. Again, because if the trunk is a problem, it trumps the shoulder. We kind of combine these two. So basically, we go through our spine, we go through our press up, our lumbar lock, and check T-spine versus lumbar spine. And then since you're down there prone already, we just decided to get rid of the lat test that we did before where you're on your back, the supine overhead lat. And we're doing a prone shoulder flexion. So they're laying there prone on the ground, prone on the table, and we have them try and flex one arm. And if it doesn't work, we try it passively. And then from there, we can tell you if there's a shoulder component. So again, it's kind of like the upper extremity. We're checking spine first and then shoulder, but we feel like we can accomplish that in one move. It got rid of the whole ER position, which was a big plus for us. Lower body, nothing's changed there, still the same. Spine matches the extension for the spine, so we have that, those are matched. The only thing we add is that seated trunk rotation, but nothing's changed there. On the rotation breakouts, we combined the tibia breakout and the hip breakout together. So now we have one lower quarter breakout for external rotation and one lower quarter breakout for internal rotation. And probably a bigger change is we only check hip rotation in the rotation breakout with the hip extended. We used to test the seated and then with the hip flexed and then extended prone. The only reason we got rid of the seated one here is because it doesn't affect the top tier. The top tier is done with the hip extended. So a lot of people are like, why am I checking hip flexed when it has no impact on the top tier? And you're right, we feel like that was probably more appropriate to check in squatting, which I'll get to in a second. So we took away seated hip rotation, and now it's just prone. And that's the same thing for internal and external rotation. The vestibular has not changed. The only thing that I think we added, depending on when you took this, we went to a tandem plantar flexion. We used to do toe walk and heel walk. Now we do this tandem dorsiflexion and plantar flexion. I think what it does, it highlights unilateral problems better. Sometimes you could have a plantar flexion that was limited, but the good side was helping the bad side. Now we test each one independently, and I think it gives you a better, I'd say, consistency. So the dorsiflexion and plantar flexion are done tandem, standing against the wall. So the actives changed. And then the last thing is squat. I'm sorry to go fast, but I know this isn't applying to everybody. On the squat, literally we did a couple things. We added ankle inversion, eversion, which I think is a big part that was missing from the squat before. And we added in the seated hip rotation. So it's not, there's a lot of debate on does hip rotation even affect the squat, but we have noticed the correlation of people who can't internally rotate the hip, that it's harder for them to squat. So we thought instead of just taking it out of the SFMA, we put it here in the squat. I would say that has potential to be modified in the future. We're still debating that, but I'd love to hear your thoughts on that. But those are the major changes that we've seen on the SFMA. Sorry to do that quick, but there was a lot of changes. And I highlighted most of them. I actually did a video in the SFMA part too, of talking about the differences between before and now. So if you want to go through that a lot slower, feel free to watch that part of the video. Now let's go back to the last part of the question, which was the head and neck in the golf swing.
Yes.
Right. So I think a lot of people always ask us like, hey, we screen for 70 degrees of cervical rotation and we check for flexion.
That's right.
Do you really need to do that in the golf swing?
Well, you do. And, you know, one of the things in the golf swing that most people don't realize is that even though the neck doesn't look like it's doing this, it's the shoulders rotating around the neck. So when I get into this position, if I do this, you can see if I stand up, I've gone through this range of motion. And the same thing on the other side as well. And then on the forward motion of the head, when I come into impact, there's a lot of players that squat, and we see this tilting, Greg, of the neck coming down. So we put a lot of stress on the flexion of the neck.
Yeah, you know, so like Dave's highlighting, the cervical spine is actually going through 70 degrees of rotation on average for most players, competitive players, both directions. Left rotation on the backswing, right rotation on the downswing. And it's combined with flexion because everybody's been told to keep their eye on the ball, right? So they kind of keep their head down. This is why one of the big problems we talk about with, you know, medically induced or mechanics that can create injuries is the early extension. Anytime somebody early extends or stands up, well, they usually keep their head down, especially if they got somebody telling them to keep their head down. It increases the flexion that happens in the cervical spine, and you wonder why we get some cervical disc injuries, right? You add that cervical flexion rotation in there, and that's a recipe for disaster.
Which we've seen quite a few. I mean, we've had some elite level players in the last couple of years that have gone through cervical neck injuries, right?
Well, that leads to the next question. Adam asks, could you go over some of your favorite cervical flexion and cervical rotation correctives? I would be happy to do that. So let me show you a couple of things that I like to do. Now, first and foremost, obviously, actually, why don't I talk treatment first? Lay on your back here. So
head, which way?
Head here.
Okay.
Everybody see me over there? Perfect. Okay, so from a treatment standpoint, I think you're asking exercise, but just from a treatment standpoint, I like to, for flexion, obviously, I like to go look at all the suboccipitals, right? So from your rectus capitis to your splenocerebellar capitis, anything that's involved in there, I'm going to look. And the way I do that is I have Dave usually tuck your chin to your chest, and I palpate. I'm always looking for and relax. And now you're going to flex your chin all the way up. And I'm palpating to try and figure out which structure tightens up first, come back down, and I treat what I find. So that's more of a fascial plane type of assessment, but I do active release. I'll do some type of where I'm holding the tissue and Dave is actively moving to try and strip those fascial restrictions or muscular limitations. From a joint perspective, remember on the cervical spine, really what I like to do is I like to challenge each of the facets to make sure that they're moving. The cervical spine, remember the way it works is if I'm going to challenge the left side facets, I will laterally flex them to the left. I will rotate to the right. That helps lock up the facets. And then I just do a little challenge. I go up and down the spine, challenging to make sure there's give on each one of those. I'll do it on this side. So if I'm going to check the right side, I'm going to laterally flex them to the right, rotate away, and then I use kind of this part of my finger to kind of make it soft, and I just challenge those facets back and forth, and I'm just feeling for springiness. And if I feel that that's restricted, then I'll go ahead and do, obviously I am a chiropractor, I would go do some type of joint corrective in there to try and open that up. So that's some of the basic scanning. I think OA joint as well. I like to look for OA joint. I actually check this, you totally relax. I'll bring the head up and I'll check OA gliding left and right. I'll bring the head down and check OA gliding left and right. I'll do what I call scoops. You just totally relax, and I'll try and scoop to the right and to the left, looking to see if there's any difference. I can feel a little difference on Dave going to the left there, so it could be closing down this right OA. So I do a joint scan, a tissue scan. Now, once I've treated this, okay, and I've gone through and I treated them, if I'm going to do some type of exercise, motor patterning, motor relearning on here, I like to do, first and foremost, you always got to remember when we get into the rehabilitation side or the relearning programs, I call it feed what you need. You have to break the bad pattern. And what usually happens here with the cervical spine is a lot of people, what they do is instead of using their postural stabilizers to stabilize their spine, when these guys get weak, if the postural stabilizers get weak, right, instead of staying nice and upright, they start to do this, the head starts to get forward. When the head gets forward, all of a sudden they're going to start using these muscles over here to help stabilize their head. They'll shut down some of these muscles. And now they're being stabilized by the back of the neck. When you ask them to touch their chin to their chest, they can't do it because these muscles are acting like stabilizers because the postural stabilizers aren't doing their job. So I always like to try and get that postural stabilization back, which is what we were testing for in the cervical breakout. What I'll do, my favorite exercise is I have them hold a band. This is a heavy band. I like a light band. And from there, you can grab wide if you need to. Dave will pull down into the T position, right? Now in that T position, if you think about this, he should be activating his postural stabilizers, right? I'm asking him to use the muscles between his shoulder blades. You'll be shocked on how many of your clients, their neck completely tightens up. And I'm like, hey, why are you using your neck? I get them to relax their head. We call it bobbleheads. So the first exercise we just say, Dave, you just relax your head, but keep your hands down. It's teaching what it feels like to have your postural stabilizers engaged, but your neck relaxed. And that's really hard for some people, right? If they can't deactivate, I'll have them do some like push into my hand and then relax, push into my hand to activate so they feel what it feels like to relax. Now, once those are relaxed, I have them bring their hands up. And I say, now we're going to do it again. This time you're going to pull down, but keep your neck relaxed the entire time. So now they pull down trying to feel like they don't have to do a bobblehead. It stays disconnected. So I'm disconnecting my postural stabilizers from my neck, right? Then we'll do this. Hands come up. Now we'll try a different plane. We'll go right hand up, left hand down. And I make sure this goes right across the chest. And I go, okay, how do we do here? And again, if they have the bobblehead, relax, they relax. And we go hands up. We do left one up, right one down. Different planes, trying to get them to trick them to get their brain to use their neck again. And I want them to train to not use their neck. Now, once they can do this, they can get their postural stabilizers and their neck's not affected, we'll start going into patterns of movement. So let's go back to the T position, so straight down. So Dave's gonna bobblehead. And the first thing he's gonna do after he's got everything relaxed is now he's gonna flex. He's gonna come all the way up. And if I give him that range of motion, he should be able to do this, right? And then he relaxes here. Now we'll go right arm up, left arm down, bobblehead. And now he'll flex. And then back up, go left arm up, right arm down, bobblehead, and flex. Good, and come back down. Now, that's for my flexion pattern. I can do the exact same thing for rotation. So rotation, we can go into T, totally relax, and you're just gonna rotate to the right as far as you can, trying to relax your neck, and you can rotate left. The only difference here, come back to center, arms up. If you go right arm up, left arm down, we always say this, you only smell your pit. In other words, you're only allowed to smell your armpit. You can't smell your armpit when the arm's down. So you can only rotate to the right here, just because of the way the levator scap works, and come back. And then arms come up, and the left arm goes up. If you rotate, you're gonna smell your pit to the left. So we go T-bar, you can rotate right and left, right up, we go right, left up, we go left. Okay, so those are some of the basic rehab ones. And then we would take this pattern to kneeling and then standing. We repeat the same things, right? Now, one last one that I think sometimes helps a lot. That's for exercises to rebuild motor patterns. If you've done your treatments and you're looking for more of a reinforcement exercise, something to try and reinforce this range of motion, I think a lot of times opening up the upper cervical spine, whether it's the OA or C1, C2, even C2 and C3 can help a lot. And a lot of times there's a program that one of our advisory board members, Janet Alexander and Dan Hellman, who are speaking at the summit, do. They do a program from a guy by the name of Guy Voyer. If you haven't heard of these Eldoa exercises, I highly recommend. They're great. I'll show you one little quick one that I like to do for opening up the fascia in the upper cervical. And I'm going to just do a real simple one. I'd highly recommend you go check out some of their stuff. Bring your knees up. Okay, so you're going to bring your legs up like this. I'll show you just a simple one. Feet are out. You can let go with your hands. Good. Hands come up. You're going to externally rotate. Turn your hands out. Good. And basically, I'm just going to show you a basic, simple one. Depending on where you put these arms, you'll see when Janet and Guy do these, they move these arms to change the level which they're going to attack. From this position here, I like him to tuck his chin, and now he's going to try and distract. He's going to slide his head towards me, so you're going to try and nope, just keep it on the table and try and extend. So you feel like you're trying to take your head off your shoulders, chin's tucked, and then from there, you're just going to slowly curl up, like you're going to just bring the top cervical vertebrae off, and they hold. That is a very difficult exercise. Dave will back me up on this. You'll feel like all kinds of muscles are working that you're not used to, and you just hold. You feel like you're distracting and relax. Usually, come on back over here, Dave. And usually we'll do that. Guy and Janet and those guys usually have them do that for about a minute. If you feel like your soft tissue work didn't open it up, that's a cool reinforcement one. If the mobility is great, we go into some of the repatterning that I showed you over there. Those are my favorite ones for cervical flexion rotation.
That's my favorite one. I love that one.
It opens up the neck.
That's really good.
Yeah, that's, if you look up on the internet, look up on YouTube, Eldoa, E-L-D-O-A, C1, C2, or C4, C5.
Yep.
And then we have a DVD, or not DVD. Look how
DVD,
old I am.
where are you going with
DVD,
that?
what year am I in right now? Okay, so
we have a course that we're developing.
there's an online course that Janet Alexander and Dan Hellman are doing for us at TPI. We're actually shooting this next month. Look for that coming to a theater near you soon.
Right.
It'll go through a lot of those exercises, which I think are really, really good. Yeah. Okay.
All right.
Next one.
What are your go-to strategies for improving ankle DF as well as improving hip ER and IR if it is a mobility
Okay,
dysfunction?
so here's the question. The question is, how do we fix ankle dorsiflexion? Let's start with that one first. What do you mean? I never find that problem. Just kidding. That is another
Huge
massive problem that we see. We talk about that in level 1. We talk about that here in the medical and SFMA. So dorsiflexion, to me, there's a couple strategies. Okay, so strategy number 1 is first and foremost is figure out, is this a mechanical problem or a neurological problem, right? You can have 3 types of mobility problems: chemical, neurological, mechanical, right? Chemical would be like inflammation, lack of blood flow. A lot of these things can cause that. It's not the most common, not saying that people don't get swelling in their ankles, it can create some problems that dietary things can help them with. But I think the question is probably based more on the mechanical blocks. Neurological, it's like, it depends on the position, right? It's, you know, as we talk about stability problems. When you have those mechanical blocks from a joint problem or a tissue problem, I think people struggle with those. So the first thing that I'm going to tell you is on dorsiflexion, and I think we're really good at fixing dorsiflexion here, is I always like to figure out, is it a joint or is it a tissue? Okay, now, a couple of rules of thumb here. If a joint is a joint problem and not a tissue problem, usually it's restricted in multiple planes, right? So if you look at your ankle, if it's just dorsiflexion, that's limited, but plantar flexion's fine, inversion's fine, eversion's fine, even tibial rotation's fine, you're probably dealing with the tissue, right? That's not 100%, but that's a good rule of thumb. If you notice, man, eversion's limited, inversion's limited, dorsiflexion's limited, plantar flexion, you're probably dealing with the joint. Another sign that it's the joint is when you're doing like a half kneeling dorsiflexion test, they're going to tell you they feel it in the front. So joints tend to be limited on the contractile side. Tissues tend to be limited on the elongating side. So a lot of times what we'll do is we'll actually, like, let's go back over here to the table. Lay on your back there again. We cover a lot of this in our online advanced SFMA class, but actually turn the other way around so they can see your legs. So if I were, you mind I take the shoe off here, Dave?
Go ahead.
Okay, so if I take the shoe off, so literally, if Dave was going to dorsiflect, okay, so when he dorsiflects, literally this side's contracting, this side's elongating. So what I'll do is you totally relax. I usually put my hand, relax your foot. I put my hand on both sides of the joint, and I say, go ahead and slowly dorsiflect. If it's limited and it won't go any farther, what I want you to do is, number 1, ask him, where does he feel like he's limited? Is he getting blocked in the front or the back? And then number 2 is I want you to pay attention. If you feel that he can't go any farther because everything's tightening up in the back, it's probably more tissue. If you feel like he can't go any farther, but nothing's tightened up in the back, it's just in the front, that's probably joint. So I'm always trying to differentiate. If the contractile side is what's limiting me, then I'm thinking joint. If it's the elongating side, I'm thinking tissue. Those are some of the signs on there. I think the best one for this is go half kneeling for me, Dave.
Half kneeling?
So put this foot forward, that knee down.
Okay.
When they do a half kneeling test, like bring your knee towards me, ask them, do they feel it in the front or the back? If they feel it in the front, I'm thinking more joint, okay, because that's the contractile side. Okay, so if it's joint, and I keep noticing no matter what I do, he feels like a block in the joint, then I think you need to go palpate the joints. So go ahead on your back for me one more time. The way I like to do this is I use for lower extremity for testing here, I use a pistol grip. So here's my hand. I take my fingers, my 3 bottom fingers, wrap it around the calcaneus, and then the webbing of my thumb goes right over the malleoli, right? So that's kind of how I hold the calcaneus. Literally what I'm going to do is I'm going to, for dorsiflexion, I'm going to check not only rear foot, forefoot, I'm going to check tarsals, metatarsals, everything, right? Even first ray, we'll go through and do some of these. But literally what I'm going to do is I'm going to stabilize the rear foot. I'm going to check, especially when I get to inversion, eversion, I'm going to check forefoot. I'm going to stabilize the forefoot. I'm going to check rear foot. Then I'm going to check talar glides, which is probably the most important here for dorsiflexion, to make sure the talus is going up and down. And whenever I'm doing this, I'm always distracting. I'm distracting the joint and then gliding back and forth to make sure that it's rocking. So I'll distract and palpate. Distract, palpate calcaneus, distract, palpate talus. I can even distract, palpate cuboid. Dave's foot's moving really well. You can feel everything is kind of moving in there. It feels good to me there. I look at the arch, amount of arch, if they're a high arch or flat arch. I think that sometimes that influences this. So I'll do a joint scan on there. If the joints are restricted, I'm going to manipulate. I'm going to go through and I'm going to do an adjustment to try and open up the joints. I think that's really, really important. Now, once you do the treatment on the joints, a lot of times now we go back and retest, and now dorsiflexion is not fixed. It's just not blocked in the front anymore. Now they feel the tissue, and now you have a tissue problem. So a lot of the tissue things, obviously we get soleus issues for this all the time. Gastroc issues can limit this. We even have some of these, and when I say soleus and gastroc, I'm thinking more of the fascia across the posterior chain over here. A lot of times some of the ligaments back here, some of your posterior calcaneal ligaments can restrict your dorsiflexion. So some of those connective tissue barriers can be big that we go after. And I do a lot of hands-on treatment for those things. I'll show you one little trick that I think helps for from the ART world. Let's do this foot. It's gonna be easier for them to see.
Okay.
Lay on your side that way. If the mic's not in the way there.
Yep.
Oh, there goes your phone. Okay, we're gonna take this just like this. I get them on their side with their foot off the ground. This leg can just relax here. Kind of do that just to kind of relax. I get their foot off the ground. Let me see if I can stand where you can see me here. This leg, my knee, acts as something that can help me dorsiflect passively. So literally what I do is I get out of the way here. I find the tissue I want to treat. With my thumb. Once I find the tissue I want to treat, I come in with my knee this way. So my knee's on the ankle. And now I can dorsiflect with my leg. I don't know if you can see that, but his ankle is dorsiflecting back and forth here with my knee as I'm treating. And I can use both hands to treat as I throw. Go the other way, Dave. It actually might look better the other way. Sorry, I'm
Ripping stuff.
up and everywhere. So
Yep.
basically, this
Oh,
my
yep,
bottom
sorry.
leg's here. So from here, my knee, you can see this, my knee kind of, I can dorsiflect this foot back and forth as I'm treating the calf here, right? That's just positioning wise, I think it's pretty cool for going after dorsiflexion. Then okay, go ahead and sit up for me.
Yep.
So we go through my local biomechanical testing. I check the joints, I check the tissue. If the joints feel like they're working, the tissue feels good, but he still can't dorsiflect and he feels like a blocking in the front, a lot of times we'll go to like a mulligan mobilization with movement. Let's go back to the half kneeling position. I like this because if this shows up, then you have more of a joint positioning or almost the joint is in a bad angle and that's creating the block. And if you can actually get them to stabilize that angle, it helps. So literally what we'll do is he'll go forward. He'll say, I feel it in the front. We come back out. And now all I'm gonna do is I'm gonna reposition the joint. And the way that we do this is we take the lateral malleolus, I push it posterior, the medial malleolus, I pull it anterior. So I'm basically doing this. You keep your foot right there. I rotate the ankle and I say, go ahead and come forward again. And I ask them, is it better, worse, or no difference? And they come back out of it. Now, instead of pushing it this way, I'm going to push it this way. So I push the lateral anterior and the medial one posterior, and I say, come forward. And I'm seeing if that's any better. Come back. I take both of them, I push them posterior. I say, come forward and go back. And I take both of them, I push anterior. So literally what I'm doing is I'm checking this, I'm checking this, I'm checking this, I'm checking this. If one of those, all of a sudden, he goes, wow, I can dorsiflect more and I can clear it. You have more of a positioning problem of the ankle versus a true joint subluxation or restriction. And that's where we'll go into some of our taping, some of our R&T stuff to try and kind of stabilize that ankle. That's kind of what we do. Sorry to throw your stuff everywhere, Dave.
That's all right.
That's some of the main things we do for dorsiflexion treatment-wise. But I think once you find the true problem, is it a talar gliding problem? Is it a soleus fascial restriction? Is it more of a, hey, the ankle is oriented in the wrong position, we need to stabilize it? You get some huge changes in that. Now, Daniel, you also asked about hip internal external rotation. I'm gonna do two things. Depending on our time at the end of this, I'll come back to that. If I don't get to that, we just did our fitness level 2 Q&A.
Yes.
All of these Q&As we put on our YouTube channel, right? You can always go on after this, probably by tomorrow, and you'll be able to see this, or within the next couple of days, you'll be able to go on there and see the fitness one. I went through a series of my favorite hip exercises for internal and external rotation on that fitness Q&A.
Yep.
So I'm not going to bore you. You can go watch that. You can zoom right to it. You'll see me laying on the ground with my legs apart doing some hip windshield wiper stuff. Watch that. If we have time at the end of this, I promise I'll go through it here too. Okay. Okay. How frequent are you seeing the client early in treatment, and how long are treatment plans to get long-term results? Sharon. Okay. So, man, how frequent are you seeing the client early? I'm always aggressive. So I like to see them as soon as possible, and I like to clear up as fast as possible. I always feel like, mobility problems are like brick walls. Exercises are like hammer and chisel. I'm a bulldozer. Most of the manual therapists are bulldozers. I like to break the wall down, and then I use the exercises to keep the wall down versus using the exercises to break the wall down. So I like to go through and clear up my mobility problems immediately. And I like to do those maybe 2 to 4 treatments real quick, like within the first week to week and a half, just to clear them up. If I can clear them up in the first session, I'm good. Then I move into the phase of active care. I'm big in active care. I don't like them doing nothing at home and they just come here and expect me to fix everything. Yeah. I always explain, if you're not helping me, then this is not going to work. Yeah. So then I'm going to show them some of the rehabilitation exercises, the motor skills, and basically I'm going to give them homework. And then I always tell them that if they lose the feeling, then you need to call me. Or if we get to this certain point in time, this is when I need to see you at the latest. And I like to start weaning them off as fast as possible. I mean, I'm one on the mentality is whoever fixes them faster gets more clients. I'm like, Dave, do you want to go see somebody 30 times or 3 times to fix your problem? I think most people want to see 3 times. They love you, but they don't want to be there all day.
No, they don't.
So a lot of people from business are like, oh, but if you only treat them 3 times, how are you gonna make money? Trust me, dentists make money a lot and they see people once or twice a year. It's literally, if you can fix me faster, more people are gonna come to you. So I like to do aggressive, hard, treat the mobility first, show them their rehabilitation exercises, start to wean them off. And obviously this is so dependent on the injury and what the problems are. If they need tissue care, and we have tools to do that. If you need some, you know, from any of the modalities that you might use that they might have access to, treatments, those types of things, obviously heavier up front and start to wean them off. I feel like that goes so far into keeping long-term good results. Just teaching them the tools they need to do to stay healthy.
I would agree.
Okay, Jared. All right, I see the cervical, thoracic, and thoracolumbar junctions, which are 2 huge areas of problems, limiting many patients' spine mobility or control. Favorite exercises, treatments for these same areas. Okay, so Matthew, great question. So I think this goes back to our level 1, goes back to our mobility stability model, right? If you think about it, you know, lumbar spine is mainly a flexor extender. Rotation, side bend, not so much flexor extender. So it's more of a stable joint. Thoracic spine is more of your mobile joint, right? Cervical spine actually has both. The lower cervical is supposed to be stable. The upper cervical is supposed to be mobile, right? Now that's an oversimplification on our model, but if you think about it, you've got this thoracic mobile, and then you got lower cervical stable, lumbar stable. It's the connection, the transition from the mobile to stable that tends to create problems, especially when the mobility is lost in the thoracic spine. All of a sudden, those transition areas start going mobile, and they weren't really designed for that. Right? So when that cervical thoracic starts doing stuff, and then all of a sudden the body responds with usually pain or herniated disc, right? So I agree with you. We see these problems all the time, and you say, I see these contributing to spinal mobility problems. Well, the first thing I'm gonna say is usually they're the result, not the cause. So I'm gonna go after the thoracic spine first and upper cervical, and hips, thoracic, upper cervical. Usually if you clean those up, then the junctions tend to get better. But I do agree with you. A lot of times we need to go hit the junction area too, right? So I feel like that when we do these evaluations, primary, take care of the mobility parts first. Now, when I go through those junctions, I think that the cervical thoracic junction, if you're asking specifically, you said treatments. Okay, so for treatments, I'll show you a couple things that I do for that. Why don't we go, let's go on your back here. Okay. I'll show you one of the easiest. And I know we have all different professions on here, so I apologize if this is out of your scope, but for anybody who does manual therapy, one of the easiest ones that I like, let me see the best way for you to see this, is, okay, if I was gonna try and open up, let's say Dave's left upper cervical thoracic area over here, especially if you've got like a rib, like a first rib or T1, I do something, I can't remember who taught me this, but it just works so good. I basically have him take, his, if I'm treating his left side, I have him take his right hand across his shoulder, right? And now literally what I'm gonna do is I'm going to put my arm across his whole rib cage. I'm kind of preparing myself for the treatment that I'm gonna do. Now what I wanna do is I wanna put my hand underneath him. Actually, I think it's gonna be better for you guys to see this side. Let's switch sides. Other arm, right, let's stay right there. Just put this hand here, right here. So basically what we're gonna do is I'm gonna try and treat his upper right side, right? So literally what I'm doing, I'm gonna stand on this side. His left hand goes across the shoulder. I'm gonna place my hand across the collarbone. And now what I wanna do is I wanna get my hand underneath onto his rib cage, and I wanna get his shoulder blade out of the way. So the way I get his shoulder blade out of the way is I put my hand here and I say, Dave, give me a big hug. Take his hand, come up around me. As he hugs me, his shoulder blade comes out of the way. I put my hand, using my thenar, I put my hand right over that CL junction, and I just have him lay back on my hand. Now, literally what that does is it usually gets him out of a position where, and that actually moved pretty easy.
Oh, great.
You're welcome. Okay, and basically, it opens up that cervical thoracic junction really, really easy. Great for first rib, too. I love that. I've seen, a lot of people do the prone ones where they're prone, they have them turn their head, and they do some diagonal. I think that one's way more comfortable. Like, I didn't hardly have to push.
No,
and that's usually an area that's really tough on a lot of people. And then for the thoracolumbar, I like doing those anterior, right? So basically, he's just laying on his back, arms curls up. I put my hand behind him. I lower him on my hand, and those usually manipulate really easy. That's why I don't usually think thoracolumbar is the cause. I think it's a result, but it's easier to treat than the CT junction. Okay, let's see. Let's see, hold on. Branch just asked the question about that. How do you like to assess and treat the obliques, especially with regards to the thorax? Okay, so how do I treat obliques? This comes in like when I just said for these junctions, you want to treat the thoracic spine. Or I should say, you got to treat the thorax. The thorax is supposed to be mobile. Yep. Now the thorax, that's a big joint, right? That's not a joint. There's multiple things going on here. Believe it or not, the number one thing that tends to restrict thorax mobility is oblique abdominal fascia, right? That literally is the number one thing we see. Number two is rib cage pliability, flexibility. And breathing has a lot to do with that. Number three would be spine mechanics, something in the spine. And number four would be even the front of the chest. So whenever I say thorax, you need to scan all those. You need to check the oblique fascia, you need to check the rib cage, you need to check the thoracic spine and the front of the shoulder. Let me show you how I check oblique abdominals. You're gonna laugh, you're gonna think this looks so voodoo, but we get lots of great reliability on this. I'll show you how we do the obliques. Dave, have a seat here. Literally what I do is I palpate. And a lot of times this is me feeling, a lot of times this is the patient telling me. Okay, I have him cross his arms. I'll show you an alternative if this is too voodoo for you. Basically what I do is I take my hands, wide base, because if you think about the obliques, it spans, I mean, literally it's your whole girdle. Imagine like you're wearing a girdle. I put my hands right over their love handles. Not saying you have love handles, but okay, so I take my hands over his obliques, right? And from here, I'm gonna say, Dave, go ahead and rotate to the right. Now, as he rotates to the right, his right internal oblique should fire and his left external oblique should fire. Come back to center. I should feel these. I go to the right again. You feel that one there, right? He can feel his left external contracting. I don't feel much over here, right internal. I don't feel much here. I should feel something. Let's come back to center. Now let's turn left. You felt that this time. Yeah, so you felt his external. Go ahead and come back to center. Go left again for me again. And come back to center. Now I just want to see if they're different. Go right again. And back to center, and go left. And all we're doing is do you feel a difference on either of us?
I do. This side, I actually feel like pain down into the groin when you do that.
When I'm holding in there. So basically, I'm kind of putting my hands on the obliques over there.
Yeah.
I think Dave feels what I feel. I feel a difference. Yeah. And literally, I know this sounds weird. They should be symmetrical. When I turn left, I should feel the same amount of like internal here, external here. When I go right, I should feel internal, external. If you're like, when I turn left, I feel both. When I turn right, I only feel one. Yeah. That's your first sign there's something wrong with the obliques. Okay, it's a weird test, but I just find it very diagnostic. Now, I don't know if I don't feel the right firing over here. I don't know if it's because my right external is tight or my left internal. I don't know which one it is, but I know there's a problem. From a treatment standpoint, you can do anything from go ahead and cross those arms again. I can go across, I can do any of my active release treatments where he actively rotates and I strip the obliques. You can go on your side. I can do treatments on the side where, again, I can take his chest forward. I can work obliques this way or the opposite direction from working internal and external. So I can do from a side position for stripping the fascia. Yep. I like doing those for your obliques. That's kind of how I attack the oblique abdominals. And it's a big deal for those, especially those tissue problems. Okay, where are we at? Okay, Chris, have you been able to come up with a hip IR correction a la Tom House isometric series for the shoulder? So I just said this earlier. It sounds like we're going to get to this anyway. Mm-hmm. I just did a great, let's say, mobility program for hip internal and external rotation on our fitness level 2. So please go watch that on YouTube. Now that you just said the Tom House, though, Tom House does have a great hip one that I didn't show. And maybe that's what we'll do. I'll show those right now. So the hip routine that Tom does, I love. I actually would do If you go look at the fitness level 2 Q&A from today,
Yep.
that gets posted on YouTube, look at some of the mobility ones, and then do these.
Yes.
I think you'll notice a huge change in hip internal and external rotation. So let me show you the ones that Tom does for hips, because I'm a big fan, obviously, of Tom's stuff. So best way to see this is probably if I go to the ground. Dave, so I'm going to move this table out of the way.
Good.
Okay, if I lay here, see me down here?
Yep. Move this chair out.
Yep. Okay, and actually, it might work best. You can see this way. Yeah, maybe. Okay, so I'll go diagonal. That's fine. Okay, so basically we start with the arms up in the air, head on the ground. And what Tom does is he has you push your, actually, you know what, why don't you, I can talk you through this, if that's okay with you. So if he lays down, arms go up. So basically what I have him do is I have him push his hands into the ground, elbows into the ground, head into the ground, shoulders in the ground, hips into the ground, knees into the ground, ankles into the ground, your whole body into the ground. So first thing we do is Tom wakes up the backside of your body, okay? After you do that, you relax. Now, keeping your hands up there, first thing he does, we call these figure fours. He puts the right leg across the left, just like that. And from here, we're gonna focus on lifting, doing a bridge. You're gonna lift up, keeping that left foot on the ground, and back down. And lift up, back down. Does it, let's say 3 times, right? After you do that, and I know Dave just did a great workout with Milo this morning, so his glutes are already firing. Then we have, Tom has you take this leg and lift this leg up in the air. And now repeat. And we bridge again. 1, 2. Now notice what it's doing. It's opening up, extending over here. It's working on a little internal rotation over here. Does that 3 times. Then we take this leg and we go underneath. So bring it all the way and lay the tibia on the ground. Let that leg go all the way out. And from here, he's going to push from his tibia and he's going to bridge from this leg. Good. And up. Try and open up that hip. You can feel how tight that is.
Wow.
Open it. 2 and 3. And now he's going to lift this leg off the ground. And he's going to try 1, 2.
Can't even get off the ground.
And let's come back. Switch legs. Okay. So now we're going to go left leg over. Left leg over.
Oh, over.
First, you're going to keep that leg on the ground.
Yep.
Bridge. 1, 2, 3. And I think these are called horizontal or vertical or horizontal figure 4 bridges on our exercise library.
Leg up,
go ahead and push up. You can always type in Tom House on our exercise library, and these exercises will come up. Put this leg underneath. Let's compare. Let's leg come all the way over here. Push from the tibia. Open up. Good. Way easier on this side.
Way easier.
2, 3. Lift this leg up. And we're opening up that hip. After he does those 3 times, now we go frog leg. Both legs like this.
Yep.
And from here, we go into 5 bridges. 1, 2, 3, 4, 5.
That feels great.
And you do those perfect and come on up. So those are some great, let's call them, they're not purely isometric, but they're not huge range of motions. And I really feel like once you go through and you do some of your stretches and you do those, man, the hips feel like they're just really open up, right? So remember, on our exercise library, just on the My TPI site, make sure you sign in, because if you're certified, it opens up the library. Go into the advanced filter in the top right, click on Tom House, and literally it'll actually, I should just show you that just to make sure you can see this. Watch this. So if I go to share and share, show you if I get over here to My TPI, go to TPI, and I go to improve my game, drills and exercises. Go to the drills and exercises, and literally right here it says advanced filter. Click on advanced filter, type in Tom House, hit enter, and move this out of the way. And literally, I scroll down. Okay, there we go. There's your horizontal bridges, right? They're all there. Just wanted you to see that. Okay. It's one of the biggest problems we have on our exercise library. There's so many of them, it's hard to find some of them. Yeah. Okay. Let's see. So that was Tom House hip ones, like the shoulder ones. All right, particular question regarding post-operative timelines and common movement faults with certain surgeries. Nicole. Well, that's a big load one. I don't, Nicole, if you are listening, there's that Q&A button at the bottom. I'd love to know if there's a certain surgery that you're interested in talking about, because I would say we have different guidelines depending on every surgery, right? So, but I would say I'm more of the aggressive, starting to do. Let me say a couple things about, like, let's say you take rotator cuff surgery. You know, there's lots of studies that'll show that 2 years out, that if you started early rehab versus late rehab, the results are the same. And I think insurance companies do a lot of these because they don't want to pay for the rehab there. but I don't really care if 2 years out it's the same. I want to know who gets back faster. I mean,
Yeah.
the golfer doesn't want to sit and like say, oh, I'm just not going to do anything because in 2 years I'll be fine.
Yeah.
So you're going to sacrifice 2 years and we can get you back in 6 weeks. That doesn't make sense. So I know why the insurance company is doing that, but that's not what the client wants. The client wants to get back as fast as they can. So obviously you always listen to surgical instructions, but I think we've seen so much evidence now that the sooner you get that moving, the better, right? Whether it's some type of weight assist, like a pull or something to take some of the weight off of them. But I like doing rehab as fast as I can. And then it looks like, okay, you're talking about a total knee. So I think that Nicole was referring to total knee replacement. So I feel like on those, obviously there's some tissue healing, bone healing that needs to happen. So as soon as the surgeon says, okay, it's okay to start rehab, I'd start right away. Usually, like let's say a total hip, right? The total hip is perfect. It's titanium or it's a brand new hip. It's all the nerves that used to give sensory input, like the knee, the total knee. Remember, you have proprioceptors, you have information coming from the tissue that's telling you what's happening. Well, that's not there anymore. It's gone. So your brain, first of all, doesn't know that it's healed. It's not getting the information, the proprioception, the balance, all that kind of stuff. So I think the sooner we can start learning that new system, building those pathways, the better. So I like starting those aggressive. So I as soon as the surgeon says you can go, I usually go, and sometimes I even go faster than the surgeon says, but I didn't say that. So I like to do those. I think that I'm always looking at my movement patterns, my top tier SFMA, right? I'm trying to clear top tier SFMA. If somebody had a total knee and they have a problem with their cervical patterns, what a great time to work on their cervical patterns. We can work on everything else while they're there, right? Then let's talk about, I think what you're getting at is return to play. Right?
You got to go through the motor learning.
So once you have the tissue healing, once you have some of the motor patterns coming back, right? The way I like to do this is the biggest problem we have with players is they try and come back too fast. And that's with everything, right? And I'm always like trying to explain to them, hey, listen, if you just wait 2 more weeks, 1 more week, it could last 20 more years. Whereas if you go back faster, it's gonna hurt. So there's really no great excuse to come back soon, right? I don't see that.
That's kind of what happened with Tiger, right?
Unless you're like a senior in high school and you're trying to get a college to recruit you and you're going to miss that drafting, or I get those, but that's so rare. So I always like taking longer. So what I'll do is I'll set ball limits. So like I explain to them, first of all, we'd start with putting and then chipping. I think that's obvious. We'd always go like we have them putt and chip, and we give them a certain number of ball limits, which we'll talk about in a second. And then we say, you stop no matter what, even if you're not feeling pain. The next day, you ask yourself, am I sore? If you're sore, you did too much. If you're not, we continue that for 2 or 3 days, and then we add. And then we check again. We never go till we're sore. We always check the next day. So I like to go putting for at least a week, putting, chipping for at least another week. And then when we go to ball striking, okay, here's what I always try and explain to my players, because they think they need to go hit a couple buckets on the range, right? So Dave, if I'm a PGA Tour player, and I know it's worse for amateurs, but I'm a PGA Tour player, and I shoot 70. Okay, how many full swings did I have? Let's think about this. Like, so how many putts would you have normally?
You'd have 30, 32.
Okay, so let's say a 30, 32 putts. So basically, I've got. So if I shot 70, so let's say I'm a good golfer. Let's say I shot 75. Okay, so let's say I had 32 putts. 32 putts. Yeah. So now I've got another 43. So I got some. So of those, how many of those are chipping?
Probably another 15 to 20.
Okay, so I'm literally in the 30s somewhere. So basically, I'm going to hit 30 balls in 18 holes.
That's right.
Right? So if someone says, I need to go hit 90 balls on the range, I'm like, since when do you have to play 18 holes? Like, it doesn't make sense. The volume's crazy.
It's crazy.
Right? So I'm going, if we're trying to get you back to playing golf, I got to get you to hit 30 balls.
30 balls,
that's it. We're back.
Yeah.
Right? So why would I have to go hit 1,000 balls to go hit 30 balls? It doesn't make sense. I have that conversation with them because I feel like their expectations need to be lowered to realize what does it take to go play golf.
That's right.
And if you look at that, how many of those 30 balls are full speed drivers?
Not a lot.
How many?
Probably 7 or 8.
Let's say it was a wide open golf course, and okay, let's say there was 4 par 3s.
Yeah.
Right. So and let's say on the par 4s, par 5s, you hit a driver. Let's say there's 14 holes.
That'd be max.
Maximum is 14 drives. Yeah. Right. So I'm like, okay, you need to be able to hit 14 drives, and then maybe you need to be able to hit another 26 irons, and you're back. You're back playing golf.
Yeah.
If you think of it that way, that's not really difficult. Now, assuming, like you said, total knee, assuming they can walk the golf course, right? But total knee is pretty simple. Take a card.
That's it.
Okay, you can take a card over there. So I like to lay it out to them that it's not as daunting as they think to get back to golf, depending on what the body part is. And honestly, the biggest operation areas that I'm the most worried about is the wrist and the neck.
Yeah.
Because they're kind of the two that tend to get players out of the game.
So
those always take longer.
And you got to be slow, and you got to watch the surfaces you're hitting on for stuff like that too.
Nicole, let me know if that answered everything you were looking for, but that's kind of a general rule of thumb over there. Okay, so it looks like we got 10 minutes left. I think we've answered all the questions. Did we get them all? All the questions that came before. So now we're going to open this up to you guys. Any other questions you have? Let's real quick while we're waiting for any questions. We got 2 weeks. What we got?
We're World Golf Fitness Summit. So hopefully you guys are going to join us down there. It's in Orlando, Florida, the 12th through the 14th.
For level 2, it's $99. Level 3, it's free.
It's free, yeah. It's a phenomenal event. We got over 500 people registered. We got about 30-something exhibitors. We've got 53 speakers. I mean, it's such a cool event to not only learn about what's going on in our business. So we're hoping that you guys are going to show up.
One of the topics, the theme is yards and years, whatever can make you hit it farther or last longer. So the years part's a big medical part. So we got a lot of great medical professionals.
It's a huge part. And you know, to this day and age, we're starting to see in the golf industry that if we lose one of those golfers to injury, you know, a 50, 60-year-old golfer, that's about a $3,000 to $5,000 a year loss to that country club. So if you've got a big country club that's got, you know, 1,000 members and you lose 10 to 20 a year because of some form of injury, and they do, that's a big hit to a golf club. So you guys are needed more than anybody right now.
And we also have medical level 3 has been posted at the end of the year. It's here at TPI for 3 days. It's great. Dr. Boyd will be here. I'll be here. Dave will be here. We kind of walk you through all the things we do. All right, we just got a couple last questions here. Let's go. Rob, during the return to playing, are you having them every day or every other day initially? So I think you're asking by treating them on the return to play guidelines. Again, depends on the injury.
Yes.
If I feel like if they're sore after they do the practice, of course I want to see them because I want to know why they're sore. I want to adjust the volume. I always will. I'm cautious. I always will opt on more treatment than less treatment.
Yes.
But I do want to wean them off of me. So I start, like I said, the first couple of weeks of treatments daily, if not every other day. And then I'll get down to the point after 2 or 3 months. I mean, I'm on call if you need me.
But this is important too, why you have a team, because if somebody comes back to play and they've come from an injury, Greg, you know, as a golf professional, I'm going to have things they want to fix or they want to start working on. Yeah. I need to make sure that I'm talking to you so that you can give me feedback.
You're bringing another thing is it's not all about injury, it's about performance too. So we could be doing things that has nothing to do with injury. Yeah. Okay. Oh, sorry, Rob, you said in the swing. So when are you having them? Are you talking about Dave from a coaching perspective? How much coaching is he having on it? So,
yeah, so you know that's again dependent on the type of injury, but I usually start small. Really, I start like Greg said earlier from the green back.
Well,
start with
I don't know if this is what you're asking, Rob, but I'm going to pause it in different ways. Let's say they're chicken winging, and that's creating tennis elbow.
Yes.
And we've gone and treated this, and now we got to change the motor pattern.
Yes.
How often do you want to see them?
So if I'm going to see them, I mean, I'm going to give them a task to do every day, and it's going to be, I'm going to limit the amount of golf balls. I might just do 20 balls in 20 minutes or 20 run-throughs of the motor program. So I'm big into what we call creating a lag measure, where I give them something to do, whether it be a drill that starts to retrain the motor pattern. And the reason why I hold the amount of balls or hold the time is because people inherently want to, if they feel something's good, they want to hit more. The problem is they get fatigued. They put stress on that area, fatigue. And a lot of times they actually go the other way. They start to think that what I'm doing is not helping them because they've gotten fatigued. If they'd have just stopped, it would have been fine.
I think it's important for learning a new motor pattern to have air detection. They need to be able to detect if they're doing it wrong. And starting out, a lot of times their air detection's off. And that's where you become really important because you're the outside set of eyes that going, he's trying to eliminate himself from a job. You're trying to teach them how to air detect. But at first, Rob, as you're saying, I think you need to teach them how to air detect, and that can take multiple times.
Exactly, and it's not so much that I'm giving them a lesson every day, but I would love to see them every day, even if it was for 10 minutes.
Yeah,
just
your members on the range. You're out there. You're like, hey,
walk out and say, let me see how you're doing. You know, make sure they're not developing a poor motor pattern or doing the same thing they were, which basically caused the injury to begin with.
Okay, I hope that answered your question, Rob.
So you said medical level 3. It's October 25 through 27 here.
Okay, perfect.
So, you know, kind of after our World Golf Fitness Summit back here.
Perfect.
And then we have one more there, Greg.
Okay.
Is the SFMA screen on the TPI Pro site? If not, are there plans for it to be?
The answer is no, yes.
No, yes.
Right now, no, it is not on the Pro app. but the answer is yes.
It will be
It is coming to a theater near you. Now, I think we've been talking about through FMS. FMS, Functional Movement Systems, has an app as well that you can actually go on and do your FMS screen and your FCS screen, and we're actually putting an SFMA screen on that as well. And then we're going to try and figure out how to link the two together, the TPI one and the FMS one, so you can get your SFMA on there. And literally what it'll do is you go through your SMA, it'll walk you through your breakouts so you don't do anything wrong. You go through and you put all it in there, and then it'll rate and rank all the priorities, tell you which things are mobility problems, which things are stability problems. And we're looking forward to that. We're actually in development of that right now. And it looks like we got last question here. In level 3, is there a manual? Like there absolutely is a manual. You can see like in the medical class, I believe we've added text to the bottom of the videos in the SFMA. I think we're starting to add text in the level 2 below the videos as well. Level 3, we have 2 manuals for you in level 3 medical. We have the entire SFMA manual from Functional Movement Systems, and then we have our injury-inducing mechanics manual, TPI, where we go through advanced swing terminology, and we go through each of the body parts on, like we talked about, reverse spinning will hurt your lower back. Yeah. Just like we do on the online class, we're going to give you a manual for each of the body parts and what we would attack first from a golf swing standpoint. Exactly. Okay. All right, everybody. Well, as always, thanks a lot for spending an hour with us. We value your time, and we're always looking for feedback. If you ever have any ideas on how to make these better, please let us know. We'll post dates on when the next Medical 2 Q&A is. And until then, hopefully we'll see you at the World Golf Fitness Summit. Thanks, everybody.